Thank you very much. An absolute pleasure to be here. I want to talk about checklists for obstetrical emergencies. And just to get the glossary part out of the way, I generally use the terms checklist, emergency manuals, cognitive aids, pretty much interchangeably. But just to be crystal clear, what I'm talking about are tools designed for the real-time support of clinical management, secondarily as training tools or a matrix for case review. I'm not talking about textbooks, practice guidelines, review articles, or other things, but they generally supply the content for the checklist that I'm going to discuss. For those of you who attended the 2015 APSF Consensus Conference, this may be repetitive depending on how intact your memory is. But just to put a little context around today's topic, it is traditional in discussing checklists in medicine to spend some time self-flagellating a little bit about how far behind healthcare has been to other industries like aviation and nuclear power. And generally that's true, but I must note that in 1924, a Philadelphia surgeon published in Anesthesia and Analgesia, if you can believe it, advocating that a checklist be posted on the wall of every operating room to guide the resuscitation of patients having arrest during operation. He was generally ignored, obviously, and it took 75 or 80 years for us to catch up. I want to point out among these efforts in the area of cognitive aids in healthcare, three in particular. Peter Pronovo's Michigan Keystone Central Line Infection Project in 2006. A complete coincidence that a photo of Peter is on your table, and the only thing I'll say about that photo is that it's at least 20 years old, or I want to know what he's taking. And then Atul Gawande's work on the WHO Safe Surgery Checklist, and Alex Arriaga's paper on the Operating Room Crisis Checklist. All three of these were lead papers in the New England Journal of Medicine. And I think it would be fair to say that the publication of those projects and their rather stunning results softened up healthcare, so to speak, to the use of cognitive aids. And you'll notice when you look at this list that a number of them are designed for what in aviation they would say would be routine operations, that is standard procedure, every case, every time. And there are others, like the ones we're going to focus on today, that are for non-routine operations when the you-know-what hits the fan. So I don't need to tell anybody who has managed one of these dire emergencies of why there's a need for checklists, but I will. That is that these are high-stress events, and they are rare. And the combination means that you cannot rely on memory to effectively guide the administration of the key steps of management. Unless you're really unlucky, you have not managed a case of amniotic fluid embolism in recent memory. And so trying at 2 in the morning when you realize that you have a patient slipping away from you to rely on cognitive function to guide care is foolhardy. And it's not only the clinical care of the patient, but you need to be managing that team and creating a shared mental model. And it's always amusing to me the fact that we often use the expression on the same page to describe the shared mental model. And in a minute, we're going to be looking at exactly what that page looks like. And in many settings, that page is actually projected on the wall. So just to take one of those three projects that I mentioned, and take a second to say the concept of the value of a cognitive aid in a critical event has been demonstrated over and over again, but again, probably because of the prominence of the publication, the work that Alex Arriaga, by the way, a research fellow at Ariadne Labs at the time, published in the New England Journal, showed a 75% reduction in the omission of critical steps. So these are simulated critical events, about 5 different events, and if I remember correctly, they identified 47 can't miss steps in the management of that group of crises, and this is what was seen. So just overwhelming evidence that experienced clinicians performance improved dramatically with the use of these tools. As my colleague Bill Berry, who was very involved in that project, says, no big surprise there. If you take a test and you're given the answer sheet, you're going to do better. I won't spend much time on this, but last year or the year before, a systematic review asking this very question, do these work, was published. And as you can see here, the answer was resoundingly yes. And one of the things that tickles me a little bit is that if you look at the aggregate difference in performance in the studied surveys, they are right where Arriaga was, 75% reduction in omissions. Now, so you may be familiar with the operating room crisis checklists that are in relatively common use, not as pervasive or uniform as the WHO checklist, but Stanford has done amazing work in this area. The one in the middle is the latest version of our compendium from Ariadne, and the electronic version of the Society of Pediatric Anesthesia PD crisis is shown there as well. So what does all this mean about maternal mortality and obstetrical emergencies? You've heard about the various causes. I don't have anything to add to that discussion, except to say that when you think about eliminating harm from those disease entities, think about it in 3 buckets. Prevention. We heard a little bit, much less than I expected actually, about prenatal care, but that is a big part of it. Recognition of the development of the event and intervention. And this is where the intervention is the focus of the tools that I'm going to discuss. And I think of that as the last and best chance to save a life. When one of those disease entities flares and becomes life-threatening, what are you going to do, and what can you do to assure that you're doing the very best job you possibly can for the patient based on what we've learned from operating room events? So I'm going to deviate a little bit and tell you my personal story about obstetrical checklists. So before I left Newton Wellesley Hospital about 2016, 2017. It's a well-to-do suburban community hospital that is part of the, now part of the MGB teaching network. But I introduced the operating room crisis checklist there. And consequently, many of our obstetricians were exposed to the OR crisis checklist, both in actual clinical care, but also in obstetrical team training simulations. And over again, they came to me and said, wow, there's so many obstetrical events that lend themselves to these kinds of tools like you use for cardiac arrest and anaphylaxis and air embolism in the operating. Wow, it would be great if we had them. So my response was, well, you know much more about a lot of those obstetrical emergencies than I do, but I've learned something about construction of checklists along the way, and maybe we should get together. And one of the activities from my almost 30 years at Newton Wellesley, of which I'm most proud, was the volunteer effort among a bunch of private practice obstetricians, midwives, labor nurses, MFMs. We met every 2 weeks for about 5 or 6 months and drafted and redrafted and revised what turned out to be a compendium of 17 obstetrician-driven crisis checklists. And a few months after we finished that, I got a call from a buddy at Kaiser Permanente named Paul Preston, who has been at this conference many years. Said, do you know anything about checklists for obstetrics? As we're putting together a task force at Kaiser to develop them. So I said, yeah, as a matter of fact, we just implemented them, and we put them in the on-call rooms and the labor rooms and so forth. He said, would you share it? Absolutely. So a couple of weeks later, Atul Gawande comes up to me and says, I just spoke to about 15,000 staff at Kaiser Permanente, and all they wanted to talk about was OB checklists. And said, was that you? And they disbanded their team, their task force, and adopted and adapted the Newton Wellesley checklist across 15 or 16 Kaiser hospitals. And the interesting thing about that is those hospitals were very different from one another. And so that's where the importance of the adaptation comes up. And then along the way, I heard that somebody had implemented them at Jefferson and in Dominican Republic and the University of North Carolina. And I realized there was an opportunity there. We have a private community hospital, mine, a university medical center, and a health system group of hospitals all doing the same thing. What was the experience and what could we learn about it? So we did a mixed methods study of the implementers at those institutions and published it. And I'll get to the punchline at the end. But last year, I became aware that all of those institutions had recently done revisions and updates, and also the Obstetric Anesthetists Association in the UK had developed the OB crisis checklist as well. So what has everybody learned in almost 10 years of use of these crisis checklists? And wouldn't it be great to compare notes and find out why they changed whatever they changed? And is there possibly a best of breed that we could produce as sort of a generic version to put out there for free, as we have done with all of the other work products at Ariadne? Not something for the 30-bed critical access hospital, and not something for Massachusetts General, but someplace in between. And we had recently developed a editing and modification tool for the OR crisis checklist, and why not adapt that? So that is the project that in the current funding environment is frankly stalled a little bit, but that is our vision to be able to bring that forward. This is a recent version of the Newton Wellesley crisis checklist, and we make it available through the emergency manuals webpage, along with a whole bunch of tools and an implementation toolkit. I apologize, I checked, and the one that's on that website is the prior version, so I am currently hounding my friends at Newton Wellesley to get us the very latest to replace for the website. But in any event, you can look and touch and feel and smell what we've done. One thing that we did with the OR crisis checklist that I think is relevant to this work as well. Here's a page from that compendium of checklists. If you hold this up against the 1935 B-17 aircraft checklist, you'll notice right away that the look and feel and the user-centered design has carried forward to modern day aviation checklists, but also this. The font, the spacing, the use of color, et cetera. We have done everything we can to learn as much from NASA, from Boeing, and other people with decades of experience in using similar tools to make them maximally effective when we need them most. The other thing, as I was about to say, is that in the OR crisis checklist, the most recent version, we tapped into some work that, again, Alex Arriaga led, and I believe this was an FAIR APSF grant-funded project to address the challenge that if I asked you, should you debrief after an OR critical event, you'd probably all say yes. And if I asked you, well, what does that look like? What are the steps to do it in a psychologically safe way to do more good than harm? It would be challenging. And the fact that that challenge exists in this study turned out to be a major barrier to it actually happening. So we have created a concise outline for a critical event real-time debriefing that is the last page in the new version of the OR crisis checklist, and intend to make it part of the obstetrical crisis checklist as well. Just a word, and I'm just about done, to address the matter of healthcare disparities. And a couple of prior speakers have spoken to the problems in the obstetrical deserts, the low-volume rural facilities, and I would add the safety net hospitals where there are special reasons to deploy tools like this. I said at the beginning, why do you need crisis checklists? Because these events are rare and you haven't had recent experience. Well, if you're in an emergency room in a hospital without an OB unit, or in an OB unit with 200 deliveries a year, your experience is even more rare with these things. You don't get to simulate or train. You don't have anybody to ask for help. So where could the need be more acute than in those kinds of settings? So there's a special need, and the connection between the rarity of the event and the importance of support is my argument why it's not just the 50% of obstetrical severe morbidity and mortality being hemorrhage. Yes, cognitive aids help in the management of that, but the more rare the events, the more compelling the argument for the availability of cognitive aids becomes, in my opinion. And let me, before I close, just acknowledge the fact that the use of these tools is a cultural change, and cultural change ain't easy and takes time, and we've thought a lot about it and had a lot of experience with doing that, and you've heard some expert speakers about how to make that happen. We like to say that these tools have value and can be embraced and used effectively in the presence of one critical ingredient, and that is humility. That is, clinicians need to be able to accept the fact that they could miss something. And this is not just for us to internalize, but we need to share that with those around us, so that when you pull out the checklist, the reaction is, oh, that guy must be a complete moron if he needs to refer to a checklist. No, that's best practice. So let's try to get there, and thank you for your attention, and I guess I didn't do too badly.